Hi, I'm Dr. Ann Kellams. I'm a professor of pediatrics and director of the UVA Breastfeeding Medicine program at the University of Virginia in Charlottesville, Virginia in the USA. I'm going to talk for a few minutes about how to counsel those who either have risk factors for low milk production or are worried they may not be able to make enough milk or are worried they aren't making enough milk. So here's a myth. Many women are not able to produce enough milk. This actually isn't true, contrary to popular belief. Most of the time, when you dig into the history of somebody who says, oh, I just couldn't keep up with what they needed, or my milk dried up, there's usually something that happened where the signaling and milk removal became less and less frequent. Maybe formula was added and then the babies weren't as hungry and they weren't going to the breast as often, or maybe they went back to work and they weren't able to accomplish pumping. So most of the time, people can produce enough milk if they get optimal care and advice and support. And the other thing that's really important is we can predict who would be at risk of breastfeeding difficulties and low milk production. And we can do interventions and provide support and management that can help those mothers optimize the amount of milk they're able to make. So instead of worrying, throwing in the towel, we encourage a feeding evaluation, a careful history, and coming up with a plan that will help this particular dyad achieve their feeding goal. So if I am counseling and supporting somebody that I know has a risk factor, the first thing I tell them is, okay, so when the baby gets here, we're not going to miss any opportunities to signal. We want to go crazy telling your body that this baby is here. We're not going to mess around with sleepy baby or baby that's not latching well. We're going to make sure from the get-go that this is happening on a regular basis. The first and simplest way to do that is ensuring skin-to-skin contact. So if mom is awake, then that baby just has their diaper on and is flat against mom's chest. Mom is watching for the face and it's pink and the airway's clear and they're breathing. And we're just spending skin-to-skin time because it's been shown that babies who are skin-to-skin will cue to feed more often. There's another great tool, and that is hand expression. So hand expression is a great way after every feeding for a newborn, and you'd want to do this at least 8 to 12 times a day to make sure that there's been some signaling to the breast that was effective and that there's been some milk removal. Here's a picture of somebody hand expressing colostrum, that dark yellow color, right into a spoon, and then we just give that right to the baby. You also don't want to miss any feeding cues. So keeping the baby with you in the room, rooming in, lots of data to show that a breastfeeding mother in close proximity to their newborn will stir when they stir, and that's exactly what we want because we want to have frequent attempts at feeding and frequent milk removal. Sometimes I will have them consider pumping. That may be for people who are less comfortable hand expressing or who are separated from their babies and aren't able to do at the breast attempts. But pumping is as good a signal as any in those early days to just let the body know that the baby's here and maximize the amount that the mom is able to produce. We also, when they're attaching the baby to the breast, as I mentioned before, want to make sure that that latch is comfortable. And by that, I mean no nipple compression or rubbing, because the nipple has about 14 straws in it, and every time it's compressed or rubbed, we are either preventing optimal flow of the precious drops or we are obstructing some of the flow. So really comfortable. And I have moms take 2 fingers and just press on the areola region, the dark circle around the nipple, and that feels one way. It feels like tugging or pressure. It's not uncomfortable. But if you use your fingers and just touch the nipple, it's like twingy or this kind of weird feeling. We don't want that when the baby's nursing. We want it to be really comfortable. So the positioning and the attachment, and just like anything else you were doing, if it was like something you started and it just didn't feel good, instead of pushing through, just make a tiny adjustment, take the baby off, relatch, but we want it to be comfortable so that we ensure effective removal of milk and effective signaling. We also have some tricks like a supplemental nursing system, which can be attached right to the breast, providing supplementation for the baby, but also signaling to the breast. You can use a syringe with a little feeding tube right into the baby's mouth in a similar way, if supplementation is needed, to do it in a way that also provides signaling. Frequent follow-ups for these dyads, and then if baby is having to eat anything other than mom's fresh milk, whether that's infant formula or pasteurized donor milk, you want to make sure that there's pumping going on. Pumping to let the body know, even if nothing else is coming out, that the baby was hungry and wanted more milk than the breasts were making. So they go, oh, okay, so we're empty, but they're still signaling we need to make more milk. So signaling that relatively empty breast is the strongest signal for an increase in milk production. So I talk about preventing the spiral, and what we mean by that is, as we just talked about, signaling and breast milk removal is a strong signal for the body to make more milk. Well, what happens if you worry or you need to introduce formula? Well, then the baby gets their tummy full, they don't go to the breast as often, the mom's body is not getting as much signal, and then the mom's body is producing less milk, and then you can see how that can spiral downward. So if this is starting to happen, first ask why. Is this somebody who's worried, but all of the objective evidence tells us the baby's getting enough? Or is this because, gosh, she's getting nipple trauma and it's been really uncomfortable and we need to work on the attachment of the baby? Is this because there's a risk factor which might delay lactogenesis 2, or which might actually, in the rare instances, limit the amount of milk that this mother is able to produce? But you don't want to go down the supplementation pathway without thinking about how did you get there to begin with, or else your chances of getting back to breastfeeding are going to be very slim to none. Think about physiologic amounts for supplementation, and there's a whole Academy of Breastfeeding Medicine protocol on supplementation, which outlines what the physiologic amounts are. It's very small on day 1 and gets a little bigger, and then by day 4 to 5 it starts to stabilize. But we don't want them to be overfull, and we don't want them to be so content that they go into a way deeper sleep and don't wake up to signal and practice at the breast frequently. You also want to be signaling. So if baby's needing something else, as we talked about before, then you've got to do some pumping or some hand expression. It is not about removing milk at that point, especially if the baby's already been to the breast. It might be about signaling even when no milk is coming out, and understanding the importance of that. And then the protocol that I mentioned from the Academy of Breastfeeding Medicine has a lot of information about how to determine whether or not this is a medical need for supplementation. So that can be a good resource.